Thank you very much, team, for the kind introduction. And it is my pleasure to be here at this meeting that we've had every year. I think that when we had that first meeting in Athens, Tim, John, and I, and Tim presented this vision of CML Foundation. I don't think any of us we had great hopes, but I don't think any of us really imagined how far we would go 10 years later and how much this foundation would have accomplished. Certainly, there's a lot of challenges ahead, and there's a lot of things to be done, and there's many gaps and needs and other things that we have not even able to scratch the surface. But I think we've accomplished a whole lot. And I think we owe it not only to Tim's vision and, of course, the contributions of John, and I'm sure wherever he is, he's satisfied, but also to the great leadership of Nicola, who's taken this foundation to the levels where we are now. The only regret I have as I saw these pictures in the introduction is that I looked at that picture of me and boy, have I aged, but oh well. So we're going to talk about the challenges of CML and where, what I see ahead. And what I want to do through this presentation is to try to look at all the whole spectrum of challenges that we face because they're broad and as I'm hopefully going to that's not me. On the future of CML, I think we need to look at all ends of what's happening if we're going to have a good outcome to all of those patients that we represent in this room. So, by the way, I think probably all of you know, but I retired from MD Anderson, another reflection of my age. So I moved now to the Georgia Cancer Center, where I'm working there now. As of 3 months ago, so hopefully you all have the opportunity to visit me there one of these days. It is very clear that we've improved the natural history of the disease. The survival of the patients diagnosed today has greatly improved from the days where we were able to do only chemotherapy to the TKI era. And not only that, but the life expectancy of patients diagnosed with CML today is much better. It is essentially that of the general population. If you look here at the 5-year life expectancy, even for patients with a complete cytogenetic response, it's very close to what an individual of the same age, same sex, et cetera, would expect. If you go farther into the 10 years, it is still very close to that, maybe a little bit of a loss because of a few patients who transform and this and that. But generally speaking, we are very close to that normal life expectancy, which means most patients will not die of CML. Now, you will notice there's a little bit of separation starting to appear in favor of the patients with a deep molecular response who are still very close to the 100% life expectancy compared to the complete cytogenetic response. So perhaps there's been some suggestion of some impact there. Now, if I go back to this first graphic that I showed you of the shift in the life expectancy, but then I put it side to side to the statistics overall in the United States with this epidemiologic database that's called SEER. Which reflects the population of 13 states in the U.S. It's not the whole United States, but it is. So this is the data that's available from just general practice, everybody who's there. You see that certainly we have improved the life expectancy of patients. Still, this brownish curve on the top is much better than what it was in the blue, but it doesn't look like what we've seen at the MD Anderson. The improvement is not quite as much. The 10-year life expectancy is close to about 50% rather than the 80 or 90% that we see at MD Anderson. And to better understand that, let me give you some example with California. Of course, in California, we always think about the movie stars and the sports celebrities and the Napa Valley and all these rich people, but it's a very heterogeneous state. And if you can see here the life expectancy of patients with CML in the different counties, the different regions of California, you see how widely heterogeneous it is. And some of that could be just variability, but when you look at the curves in the top and the curves in the bottom, there's a huge discrepancy there. But even more, if you look at the different eras, and the top left, you see before the introduction of tyrosine kinase inhibitors, it was a lot more homogeneous. It was bad, but everybody was equally, they had the same access to the same things. It started spreading out when we had the tyrosine kinase inhibitors, and you see from 2010 to 2015, when you would imagine everybody has access to TKIs, everybody has access to monitoring, every physician knows what they're doing and all of that. Well, that heterogeneity is very disturbing. So one way to look at this is by this heat map, where you see that the 5-year overall survival is represented by these different regions. Just to put it in perspective, Just to put it in perspective, Los Angeles is down here, San Francisco is somewhere around here, down here is San Diego, and the darker colors represent essentially a 0 overall survival. The lighter colors represents 100% overall survival. Some of them have no data. But you see how heterogeneous it is, even in the most recent era where there's, you would expect this good penetration. And an analysis that we did then was to look at the distance from where the patient lives to a comprehensive cancer center. Essentially, that means a specialized center where there's all this research and all these things. And what becomes very clear is that if you live more than 75 kilometers away from a comprehensive cancer center, you are not going to do as well as if you live closer to one of these comprehensive cancer centers. So clearly, even though we are talking about the U.S., we're talking about a state that we all think like very glamorous. The impact of our interventions, of our knowledge, of our therapies has not gone equally well for everybody in that state. So if you take that throughout the globe, it would represent that great heterogeneity that we see in the countries that are represented in this room. Now. Some of that may be due to what the clinical trials, but many of you that have heard me speak know that I hate that expression of the real world. And this is an analysis that we published a few years ago when we looked at all the patients that were treated frontline at our institution with tyrosine kinase inhibitors, some on protocol and some off protocol. And the off protocol were because they had their insurance didn't approve the protocol, or they did not meet criteria, so they were sicker, they had a higher creatinine, they had some of the exclusion criteria. And as you can see, the outcome is exactly the same. There's no difference between the protocol and the off-protocol patients, and they're the same patients. Their median income, their education, their lack of insurance, or it's exactly the same. But I think that one of the differences between the on-protocol approach and the off-protocol approach is how we monitor the patients, how we follow the patients. And that has been shown in this analysis from a practice in the United States, where they looked at the way they were monitoring their patients, and they realized that at any given point, up to 50 to 60% of the patients were not having the recommended monitoring that the guidelines suggest. And when you look at the impact of having or not having the recommended monitoring has on the long-term outcomes, survival, or progression-free survival, as you can see that the patients that are not well monitored, they have an inferior outcome. So the patients on protocol, certainly they are selected, but some of that is that you are monitoring them more rigorously. I think that patients who are not on protocol, if we monitor them exactly the same as if they were on protocol, we would have much better outcomes than what we just excuse ourselves as saying it is the real world. Now, one of the things that I find very challenging when you're trying to analyze the data is how variable the data is and how much it shifts depending on how you look at the data. So this is the historical data from the IRIS, and if you remember that old TOP study where we randomized patients to standard versus high-dose imatinib, and it was called a negative study because all we got was earlier responses that somehow now have become fashionable. So these were the data between for transformation and events. When we got the NSTMD and the decision studies, you see that with the second-generation TKIs, the rate of events and the rate of transformation went down. However, when you look at the difference between the rate of events and transformation in the old studies with imatinib and the rate of transformation and events with the new studies, it went up. So we constantly change our definitions, we change our approach. Sometimes we may be tending to change therapies too quickly for minor toxicities or other things. So we need to be careful on how we are approaching this and how we interpret the data over the long term. This is also reflected on this analysis of the patients in the randomized studies of nilotinib, dasatinib, or bosutinib against imatinib. If you focus on the broken lines, all of these studies have shown that the second-generation TKIs are better than imatinib. But if you look at the control arm, which is the broken lines, all of that is imatinib 400. Look at the rate of major molecular response at month 12 between some of the earlier studies, for example, the dasatinib study and the new bosutinib study. There's a big difference of about 10 to 15% rate, or probably more than that, between those two rates. So these things change significantly based on how we manage the patients, how we interpret the data, and we need to be very, very cautious with those interpretations. Now, with that background, I think it is very clear that the CML has evolved in many ways. Our treatment has evolved, and it is remarkable that in the most remote parts of the world, we are starting to be able to get them to these TKIs, as just mentioned by Pat and team. With that, we also have better monitoring tools, and we're getting to even better ways of doing PCR, digital PCR, et cetera, that's going to help us better manage our patients. And with that, our endpoints are changing. We're no longer just satisfied of getting hematologic response, at least not when we are able to do the top two things fully. But we're going to the deeper molecular responses and the sustained molecular responses because the goals of therapy are changing. We certainly want our patients to live longer, but as we have gotten them to live longer, we want them to get to the point where there's no relapses and eventually where we can stop therapy. So the treatment-free remission then has become an important goal of therapy for many patients. I already mentioned the issue that for many patients, we're not talking about how important it is to stop therapy. We're talking about how important it is to start therapy. But when you are able to get to these points, treatment-free remission is very important. You know these data very well. The probability of achieving a MR4.5, a deep molecular response that can qualify you for a TFR, we're starting to learn about how often we can get these. And granted, all of these curves represent achievement of MR4.5, not sustained MR4.5, which is what we need for TFR. But still, it gives you some idea of how often we can get there. And in general, you can see that grossly about with second-generation TKIs, 40% with dasatinib, this is 5 years, 55 to 60% with nilotinib can get there. With imatinib, we can get there. This is CML4, but it takes 10 years to get to about the same point. Now, I bring up these two studies because this is the TIDAL-2 from Australia and the MD Anderson, where with higher doses of imatinib, you might be able to get to similar places. Remember, these studies, high-dose imatinib and quick evolution to nilotinib, the patients are falling behind. These are straight higher doses. So it is important that we keep that in mind, as that may be an option, that may be the one option that some patients around the world may have to try to push to these MR4.5 to get them to consider treatment-free remission. With the use of, as I mentioned, we're not just interested in getting to MR 4.5, but sustained MR 4.5. And the best data as to how often we can get that is from the NSTND at 5 years. As you can see, with nilotinib, about 40 to 45% of the patients can get there, whereas with imatinib, it's only about 25% of the patients. Now, the predictive factors that tell us what patients are more likely to get a sustained MR 4.5. We presented this analysis some years ago, and clearly using a second-generation TKI as opposed to imatinib, or age, interesting enough, older patients, great. For those older of us, platelets and an early response give you a better chance of getting to a sustained MR 4.5. We also developed a predictive model looking at that probability, a bit of a more complicated, complex analysis. And we looked at two things: the best fit average, meaning what is the average PCR of the patients who eventually get to a sustained MR 4.5 at different time points. And then the minimum acceptable, where, if you're not there, you have less than a 5% chance of eventually meeting a sustained MR 4.5. So, for example, at 3 months, the average patients that gets eventually to have a sustained MR 4.5 is a 0.05. So they're already a little bit more than an MMR. Whereas the minimum acceptable is 1.5. So if you're 1.5, above 1.5, your chances of eventually getting to a sustained MR 4.5 anytime in the future are less than 5%. So that's very valuable because it can give you some expectation of what your patient's going to be doing longer term. We are presenting at this meeting, one of the things that are complex is that we always look at this and that variable, but there are many things that we're trying to incorporate into a decision of a patient's choice of therapy. So how do you incorporate that? So now with artificial intelligence, you can get into those kind of algorithms. So here, what we did is we've done this program that we're talking about, we're calling the Leukemia Artificial Intelligence Program, or LEAP. And we applied it to CML in over 600 patients treated with frontline tyrosine kinase inhibitors. And we incorporated more than 100 different characteristics from social and demographic and clinical and treatment and many of these things into this complex analysis that I'm not going to go into any detail. But then what we did is we did different permutations, and we separated the patients 3 different times into a design and a validation cohort. And once we developed our model, we applied it. And when we looked back at those same patients and we said, those patients that the algorithm, what would the algorithm, what would it have predicted would be the best treatment option for this patient? And then we divided the patients into those who actually received that treatment that the algorithm would have predicted. Of course, when we did that decision was not because of the algorithm. And what happened to the patients who were treated with something that was not what the algorithm would have chosen? And as you can see, it is very predictive for overall response and for 5-year outcome. You see, for example, if we pick the recommended TKI, the probability of sustained MR 4.5 was 39% versus only 16% if we pick a TKI that's not what the algorithm would predict. All of the other outcomes, anywhere from failure-free survival to overall survival, are better according to the algorithm. The algorithm has to be perfected. It still has some issues with sensitivity. But I think that these kind of algorithms would be very useful for our patients. And the beauty of this is that you can adapt them to what is available in your own place. So I think that this is one of the things where we're moving to in the future for CML. Now, going back to the treatment-free remission, I want to just highlight the fact that I mentioned that only a fraction of patients can get to the sustained deep molecular response. And only a fraction of those of the patients who get there, about half, can sustain the response without having to resume therapy. So the bottom line is that TFR is a reality, but it's a reality only to some of the patients. And let's not even talk about the patients who have access to the given drugs, etc. So we need to do much better than this. And to do better than that, one of the options is to soften the criteria for treatment-free remission. So, for example, instead of the STEAM criteria, the Euroski has used MR4 for 1 year to consider treatment discontinuation. And the results look actually pretty good. However, when you put side to side the STEAM follow-up study and the Euroski, it's hard to compare different studies. But in general, to me, it looks like you do lose something by softening the criteria. So it is some help, but I don't think, to me, that is the answer. I think we need to look at ways to better get the patients into the strictest criteria that will minimize the risk of relapse. One other option is to change therapies. We've done a change with an SCMR. I won't go into the details. You all know what it is. But the bottom line is that about 25% of patients that were switched to nilotinib were able to get an MR4 maintained for a year. If you put that into this column, the imatinib-treated patients, and of those 74% patients who hadn't achieved, 25% will improve. You add them to the 26, you'll end up getting to the 45%. So that's good because you rescue these patients, but we've reached that ceiling. So we need to do better than that. We have done a different model, also using artificial intelligence, looking at trying to predict what's more likely to get a patient into an MR 4.5. And this is a sample patient, a patient that starts with dasatinib, gets some response, then has some pleural effusion, and you need to decide what to do next. And this algorithm can calculate what's the likelihood of this patient getting a sustained MR 4.5 if you decrease dasatinib or change or whatever, and you can pick what's the best option for that patient if you're going to do this kind of change as in an SCMR. We also have some predictors of what's more likely to minimize the molecular recurrence, but I think more and more we're looking at immunologic markers because they seem to be very critical of the predicting the likelihood of relapse. This is our experience at MD Anderson, and as much as I've been accused by many that I hate treatment discontinuation, this was almost 100 patients. We have about 200 by now, most of them my own patients. So, and the results look very similar to any other series. But one thing that we constantly been shown, we reported that in our first report about 3 or 4 years ago. And here again, if the duration of MR 4.5 is more than 5 or 6 years, the likelihood of relapse is much lower. So I think that may be something valuable. In the end, we know that TKIs alone do not eliminate the earliest progenitors. So there's been a lot of interest in combining with other agents that may help us finish that task. There's been combinations with interferon, and Andreas Hochhaus is going to present a follow-up of these results during this meeting. This is the early results that he showed. They were still blinded as to what was Group A and what was Group B, but there were some, earlier responses. But really, they seem to be merging at the end. It'll be interesting to see what he presents to us in the next couple of days. A similar approach from Australia, although this is a single arm, and again, very good early rapid responses. Again, we'll want to see what happens in the long term. But also combinations. We did this with azacitidine. We only had 3 patients, and we saw a very nice decline on these patients that had been very long on imatinib. Unfortunately, the logistics of doing azacitidine and whatever make it an impractical approach, in my opinion. We added ruxolitinib to imatinib, and this is a complex graphic, but essentially it didn't work. We didn't get any improvement, so we had to stop the study because of futility. There's interest in adding venetoclax, and there's very good preclinical data that I'm showing you here very briefly to suggest that it can eradicate the earliest progenitors if you add it to tyrosine kinase inhibitors, and that's the approach that's being pursued at MD Anderson. There is an interest of combining with Asciminib because there's nice preclinical data to suggest that it prevents the emergence of any resistant clones. So there is a large study, multinational, many of you are participating on the Ask for More. There's an MD Anderson study combining it with dasatinib, nilotinib, or bosutinib. This is with imatinib. But in the end, these strategies need to meet certain criteria to make them applicable. They have to be convenient. They have to really eliminate the stem cell and not just decrease the PCR early on. They have to have minimal or no toxicity because we don't want to pay too much up front. The cost of these combinations also needs to be considered, and they have to be finite. You need to, at some point, be able to stop both drugs if it is going to be workable. So when you look at a patient and you diagnose the patient and you start the treatment, you start getting your endpoints until the point where you stop therapy. And I frequently say that TFR really doesn't start there. It really starts here at the beginning of the treatment. We need to start from educating our patients and doing the best monitoring and the best approach from the beginning of therapy. I'm going to skip some of these because I know I'm late. I'm just going to conclude with this operational cure, something that John Goldman brought up in the days of interferon with Moshe Talpas, talking about how many patients would be living with their disease. And we can achieve at least that for the majority of patients if we can do it well. And I'll remind you, as Don Quixote said, until death, all is life. I think that we want to aim for TFR for as many patients as we have, and we have a lot of work to do to get there. But we need to make sure that our patients can at least get a good outcome, even if they need to have to be with the drug. But we need to work on getting them access to the drugs, good monitoring, good management, so that at least they have that opportunity that not everybody has, even in the United States. So I'll stop here, and I thank you for your attention.